This program contains graphic images and discussion of medical procedures. Viewer discretion is advised.
Hello and welcome, everyone. My name is Saras Ramanathan. My partner in crime here is Dr. Neeti Parikh. We are both here to start this course on ocular disease and give you all a sense of why we are passionate about the eye and share our passion with you. Our course objectives for this spring are to identify major ocular structures. We really want you guys to understand what the eye does, how it functions, the different tissues, and how when some of those functions don't work properly, there's what kind of diseases commonly come about and what our current treatment regimens are for those diseases. Now, I always say, let's start at the beginning, because you have to kind of understand how the eye works to really then understand what happens when it doesn't work. So this is the eye. This is a pretty simple looking structure. There are focusing elements in the front, the cornea, the lens, and the pupil. They all help focus the light, and they focus that light on the back of the eye, specifically on the macula and the rest of the retina. So that seems kind of simple. Of course, in reality, all of that is very complicated. But I often say that the eye is like a camera. Just like the camera has focusing elements in the front, so does the eye. Just like the camera has film or now an SD card in the back, the eye has the retina in the back, an image capture device. And we're going to systematically talk about each part of the eye. Now, we couldn't start talking about the eye unless we also talked about the structures that cover and protect the eye. So in effect, the lens cap in the camera analogy. So we're gonna start by talking a little bit about the external structures of the eyelids, the conjunctiva, and the tear film. All of those structures help to lubricate and protect the eye and keep it seeing well. When those tissues don't work, we have dysfunction such as dry eye, where there aren't enough tears, the eye doesn't stay properly lubricated, or blepharitis, where the oil glands of the eyelids don't work properly. We're not going to talk about that today, but you're going to have an awesome lecture from Dr. Jeremy Seitzman and Dr. Julie Schallhorn about all of those external diseases, as well as diseases, surgical and non-surgical diseases of the cornea. Now, when the eyelids don't work properly, we get all kinds of troubles like redness and sagging, drooping, bulging of the eyes, or swelling. And one of our colleagues, Dr. Brian Wynn, will give you a terrific talk about eyelid dysfunctions and malposition and what we do to treat all of that. We'll move from there to glaucoma, a discussion of glaucoma. Now, to understand glaucoma, we really have to think about the iris, the diaphragm, if you will, of the camera. That's the iris and the ciliary body. So in the eye, there is a structure back here behind the iris, behind the colored portion of the eye, called the ciliary body. And it produces a fluid called the aqueous humor, whose express purpose is to nourish all of the structures of the front part of the eye. And this blue arrow here shows you that the fluid is produced back here in the ciliary body. It travels through the pupil, bathing the lens and the cornea in nutrients, and then is drained through the, quote, angle, this angle that's made by the cornea and the iris. It drains into this structure called Schlem's canal and the trabecular meshwork out of the eye, and there's this constant cycling of fluid. If there's a blockage in anywhere on that pathway, then there is going to be buildup of fluid and often high eye pressure, and that's what causes glaucoma. Glaucoma is a particularly difficult disease for patients to know they have. It's silent. It results in a characteristic loss of peripheral vision and associated changes in optic nerve appearance. These changes are often associated with high eye pressure, but sometimes not. And it tends to be symptom-free until very late. So that means that people have glaucoma and they don't know about it until their visual field gets very constricted. Our glaucoma colleagues, Dr. O, Sun, and Padmanabhan, will give you a terrific talk on causes of glaucoma, manifestations of glaucoma, and treatments for glaucoma. We have a lot of new treatments for glaucoma, and I think they'll give us the cutting edge on what's happening. We'll move then to talk about the retina. The retina is like the film in the camera. The retina is in the very back of the eye, and the function of the retina is to take that light image that is presented to it and transduce it into an electrical impulse that is then sent to the brain. Now, you can imagine that it takes a lot of complex circuitry for that to happen. There are 1.5 million retinal nerve fibers, and they all communicate in a very complex system to encode that visual stimulus into an electrical message to the brain. We are going to talk about all kinds of retinal diseases. So when I look into the eye, this is what I see. I see the retina. There's the optic nerve, the retinal blood vessels, and all these nerve fibers. And right in the center, this dark area, is what's called the macula. And the macula, that's the part that we use to see the best. So when we look at something, we are pointing our macula at that object to see it especially well. And unfortunately, it is the macula that is the target in a bunch of diseases, especially age-related macular degeneration, one of the biggest causes of vision loss in this country, as well as diabetic retinopathy. We are going to have a talk by Dr. Melissa Newwelt and Dr. Jackie Duncan. They will tell us about these two diseases and other diseases that affect the retina and how we are currently treating those diseases to help our patients see better. And finally, we'll have a talk on childhood diseases of the eye, pediatrics and strabismus. Now, I hate to say it, but my camera analogy doesn't work that well for pediatrics. In children, it is the muscles that move the eye that often can cause trouble. There are 6 muscles that move the eye in all different directions. And when those don't work or they're out of balance, you have problems like strabismus, which is crossed eyes, or lazy eye, amblyopia. And Dr. Manasa Indaram is going to talk about strabismus, amblyopia, and other pediatric eye diseases and how we can treat those to help preserve a lifetime of vision. So today, let's get down to our topic, which is cataract. A cataract it forms in the lens of the eye. For most of us with healthy eyes, we have clear lenses. As we get older, with certain medications, with increasing sun damage or surgery or illness, that lens can get cloudy or somehow opacified such that light can't get through it properly, and that gives us blurred vision. So our objectives today are to talk about cataract, to define it, to describe what you might notice if you were to develop a cataract, and what the surgical as well as non-surgical treatments for cataract are. We specifically want to talk about lens implants because that's a complex discussion. And so we want you to know what's involved in choosing the appropriate lens implant if cataract surgery is a choice that you need to make. So in my camera analogy, the lens of the camera is just like the lens of the eye. In the eye, there are 2 structures that focus light, both the lens and the cornea. I'm going to talk a little bit about focusing because it's important to understand how the eye focuses so that you have a sense of how we go about choosing lens implants around cataract surgery and figuring out what lens implant is the right choice for you. Again, the treatment options around cataract and cataract decision making and lens implant choice have become even more sort of broad, and so we want to really help you understand what that's all about. So how does a normal eye focus? Light comes in to the front of the eye. The cornea and the lens both participate in focusing such that we have a nice clear image that focuses on the retina. The cornea does about 70% of the focusing. It does the heavy lifting, and then the lens does about 30% of the focusing. But the lens can move forward and backward in the eye, and that's how we're able to focus at distance and near, especially in youth. The pupil provides the aperture change, so that just as a camera changes its aperture size, the pupil changes too, so that it allows just the right amount of light in. Abnormalities of focus result in nearsightedness, farsightedness, and astigmatism. And if the lens is cloudy, then you're also going to have blur that's caused from cataract. Now, abnormalities of focus can be refractive error, so nearsightedness, farsightedness, and astigmatism, as well as cataract. The nearsighted patient will have light that focuses in front of the retina. The focusing elements in the front of the eye, the cornea and the lens, are just, if you will, they're too strong, and they focus too soon, too in front of the retina. And as a result, the retina gets a blurred image, it gets defocused light. The farsighted patient is the opposite. The focusing structures in the front are not strong enough. By the time the light hits the retina, it is not yet focused clearly. It wants to focus behind the eye, and so the retina is presented with a blurred image. Now, the person with astigmatism has a different problem. They have a problem where the cornea, that front focusing surface of the eye, has two or more different curvatures. So a spherical or a normal non-astigmatic cornea is shaped more like a sphere, like a basketball, such that in every direction, the curvature is the same. But someone with astigmatism has a cornea that's shaped a little bit more like a football, where the curvature in one direction is different than the curvature in the other direction. One direction is steeper and the other direction is less steep. As a result, those different curvatures focus differently on the back of the eye. The steeper curvature focuses in front, and the flatter curvature focuses behind. And the retina then gets different images, all blurred, but those multiple blurred images focusing or hitting the retina cause not just blur, but also distortion. So the vision with astigmatism is a little bit distorted as well as blurred, kind of like looking through those circus mirrors or carnival mirrors. So these three criteria are very important because we can correct those with spectacles. That's the easiest way. With contact lenses, also a great solution, as well as vision correction surgery like LASIK or PRK. And you'll hear about those in Dr. Schallhorn's corneal surgery lecture. It's important for us for cataract because we can also fix all of those problems with cataract surgery or lens surgery. So let's talk about that. Now, cataract, remember, I said cataract is any kind of opacification of the lens. Cataract is important because it is the #1 cause of vision loss in our American population, or sorry, in worldwide. Fortunately for us in the United States, our patients with cataract get very timely and effective care, and so we are able to provide to help people see very well without waiting too long. This is just a picture of a lot of different types of cataract. People are always surprised when I tell them that there are different types of cataracts. Some of them are very dense and opacified. Some of them are splotchy. Some of them cause difficulty seeing at night. Some of them cause difficulty seeing in bright daylight. So as a result, the symptoms are going to be varied. You might have blur, glare, dull or dim vision. Maybe you need more light to see. Maybe you need dimmer light to see. Many people, after having stable glasses prescription for years, now all of a sudden they need a new pair of glasses every year. That's all because as the lens gets more and more dense from cataract, the refractive index of that substance, the lens material, changes your prescription for glasses. So when we always try a non-surgical approach first. So we always try changing glasses to see if that makes people see better. If we can improve your vision with glasses, that's usually what we'll choose. But at some point, glasses just don't work anymore. And if you find that you've tried glasses, but you still can't see well enough to do the tasks that you need or want to do, then at that point, we think about cataract surgery. Again, surgery is indicated when that cataract is bad enough that we cannot help you see well enough to do what you need to do without doing surgery. Because at that point, the risk of the surgery really is outweighed by the benefit. There are several types of cataract surgery. The state of the art right now is phacoemulsification. It's a very small incision cataract surgery where we make a 2.5 millimeter incision just big enough to insert our ultrasound probe. That probe delivers ultrasound energy to the cataract to break it up into small pieces. And then there's a little vacuum attached to that probe, and the vacuum sucks out the little pieces that we've created. Sometimes we need laser. It's called a femtosecond laser, and that breaks up that cataract into small pieces for us before we even get into the eye. That helps us because sometimes the cataract is super dense and we really need help breaking it up so that we don't need to use so much ultrasound energy. And then there are other times, rare, but occasionally, when the cataract is just too dense to remove by either laser or ultrasound. And then we have to make a large incision and take the lens out whole, kind of like delivering a baby. We don't do that all that often, but occasionally we need to. And that is also a great surgery with excellent visual rehabilitation. So I'm going to show you a video of cataract surgery. I'm just giving you a heads up in case anyone feels uncomfortable with that. But I also, before I start it, I want to tell you my peanut M&M story. This is often a story I tell my patients while we are in surgery. Patients are awake during surgery. We're often having a conversation as I'm doing the surgery. So I always say cataract is like a peanut M&M. There is a thin candy coating around the outside. There's a hard nut in the middle and a soft chocolate outer layer. Our goal is to peel a window, an opening in that hard candy coating, deliver ultrasound to that hard nut, aspirate it out, suck it out with vacuum, and then gently suck out the soft chocolate, leaving the hard candy coating intact to hold the lens implant that we put in. So let's look at that, and I'll sort of tell you what's going on as the video plays. So here you can see that I am creating a window. I'm tearing an opening in that hard candy coating. That's the lens capsule. That capsule is only a few micrometers thick. It's super thin, and we have to take care not to damage it during cataract surgery. Now I have inserted my ultrasound probe. I'm delivering ultrasound, and I'm also cutting that cataract, that nut, that hard peanut in the center into small pieces. So you'll see that first I cut it into half, and now I'm cutting each half into little pieces. Everybody's different in terms of how many pieces they want. I like 6 pieces because those are kind of like a piece of pie. I seem to have a lot of food analogies for my cataract discussion, but I kind of cut the cataract up into 6 pieces because those are pretty, I don't know, they're appropriate size to take out without too much trouble. And then I use my ultrasound and vacuum to cut and suck those pieces out. Once I have, and as I do it, I'm trying very hard to stay in the middle of my hard candy coating window, because I can't suck up the capsule. I can't suck up any part of that hard candy coating. So now I'm going to take out that last little bit of cataract, or that last little bit of the hard nut. And now you'll see that I've used a different vacuum only handpiece to suck out that soft chocolate as I leave the capsule or candy coating intact. So that candy coating is now nice and clean. We're going to inject the lens implant. It is made out of acrylic. You don't see it or feel it. We inject it all rolled up like a taco. It unfurls inside the eye, and it has two little feet on each end, here and here, to hold the lens in place. And that lens stays in for the rest of your days. We don't want to change it. We don't have to change it. And that capsule, all the structures that hold the capsule and your natural lens in place, all of those structures hold the lens implant in place. So now, points to remember are that cataract is an opacification of the natural lens of the eye. It might be a splotchy opacification. It might be a dense white opacification, like I'm showing in this picture. Lots of different types of cataracts and appearances of that cataract. But all cataracts result eventually in decline, vision decline. Sometimes we can, early on especially, we can help you see better even through the cataract with new glasses. But when that doesn't work, when your vision is not satisfactory even with new glasses, then we take those cataracts out and we put in a new lens implant. The lens implant discussion is super important. And so at this point, I'm going to turn over the talk to Dr. Parikh, because she's going to tell you all about the lens implant and what considerations you should have when choosing the right one.
Okay, so Dr. Ramanathan's done a really nice job of explaining to you guys what cataract surgery is, but that last piece of the surgery where you put in the lens, you know, there are a lot of different types of choices, and it's a difficult decision to make. So we thought it'd be really nice to spend some time talking about the actual intraocular lens implant. So if you remember, you know, you need the lens to be able to see properly. So the lens acts as a refractive surface. So it bends light rays that enter the eye so they can focus onto the retina so you can see clearly. So during cataract surgery, you take the lens out, but you have to replace it. Otherwise, you won't be able to see. So the intraocular lens it's a thin artificial lens that replaces the eye's natural lens, which we remove. And most are made of plastic compositions, usually acrylic, and they're coated with some sort of special material to help protect from UV rays. And I bring this up because people often wonder, you know, is this something that I'll have an allergic reaction to, or is it something that my body will react to? And it won't. It's made of inert material. It's just made of plastic. So it's not something that you'll have some sort of rejection or autoimmune reaction to. There are many different types of intraocular lenses. I'll refer to them as IOLs from now, but many different types of IOL types to choose from. And choosing the right IOL can be a difficult decision because, especially now, you know, as technology advances, there's so many different options. And you really have to take some time to, you know, think about what your lifestyle, what activities are important to you, how important is spectacle independence and for what activities, and also your overall eye health and your budget before you make a decision. And like I said, it's not always an easy decision. You know, you've already decided on having the cataract surgery, and then you have to make another decision on what type of lens to put in. And it takes time. So we'll go over what some of the different types of lens options are for cataract surgery first, and then we'll talk about some of the important factors when it comes to making a decision. So many different types of IOLs, and I'll go through all of these separately. There's monofocal. Monofocal means that the lens will correct for one distance. Toric means that it corrects for astigmatism as well as whatever distance it's correcting for. There's something called monovision, where each eye targets a separate distance. So one eye would be corrected for near, and then one eye would be corrected for far. There are also premium lenses, and these include the light adjustable lens, accommodative lens, multifocals, and extended depth of focus. And I'm going to go through all of these individually. So First is what's known as the traditional monofocal IOL. This is the one that I would say most patients still choose, but it is the lens that had been used for years before we started developing newer lenses. Monofocal just means that one distance is corrected. So monofocal lenses are designed to provide the best possible vision at one distance, but they're limited in range because it's only one focal point. And what that means is that when you remove your natural lens, which is your cataract, we replace it with this new lens, and this new lens is going to correct either your distance vision or your near vision, and then you would have to wear glasses for the other. So if you decided that I'm going to have a monofocal lens that corrects for distance vision, you'll be able to see far, like TV and driving, well without glasses, but then you'll need to wear reading glasses for computer and reading in your phone and things like that. You can also do the opposite. Some people are just used to being able to read up close without their glasses, and they put them on for distance, and they want to have the same type of lifestyle after cataract surgery. So you could target for near, but that would mean, again, because there's only one focal point, if you target for near, you see well up close without glasses, you can see your phone or read, but then you would have to put them on for driving and watching TV. So that's what's known as a traditional monofocal IOL. We also have a toric lens. Toric lenses have extra built-in correction for astigmatism. So if you remember from Dr. Ramanathan's talk a few minutes ago, astigmatism is an imperfection in the curvature of your eye, and it causes blurred vision at all distances because you don't have a single focal point. So even if we correct in a person who has astigmatism, even if we correct, let's say we are correcting for distance vision, if we don't correct for the astigmatism component, if there is a significant amount of astigmatism, the vision will still be blurry without that correction. And again, just like everything, astigmatism can be corrected with glasses, but if we're doing cataract surgery, it's nice to be able to correct for that with the lens implant too. So that's what a toric lens would do. It would have that extra built-in correction for astigmatism. And then again, it'll correct the astigmatism so then the image is clear, whether it's a distance target or a near target. And I just want to mention that all the various lens options that we'll talk about, including all the premium lenses, they have a toric option as well too. So any lens that you choose, if you have astigmatism, you can use the toric option for that lens, so the astigmatism can and will be corrected for. So, monofocal and toric monofocal lenses, likely the most common still, but you still have to wear glasses for something. So let's say you target for distance, you correct for distance, you have to wear glasses for up close or vice versa. So then, the next obvious question is, there's so much technology out there. What are the options for reducing glasses dependence? So what's out there? So there are a few options that we have. The first is monovision, which I'll talk about next. And then there are what are known as premium IOLs. And those include the light adjustable, accommodating, multifocal, and the extended depth of focus. And the goal with these lenses just is to try to reduce glasses dependence for either all distances or a range of distances, but just to reduce the likelihood that you'll need to wear glasses all the time. So monovision means that with monovision, you still use a monofocal IOL. So each lens, each IOL still has one focal point, but you choose a different target in each eye. So essentially, the lens that's put in one eye will correct for near vision, and then a lens that's put in the other eye is going to correct for distance vision. So the idea is with both eyes open, you should be able to see pretty well in a distance and then also pretty well up close. And that's what monovision means. Ideally, with monovision, you want to target the dominant eye for distance and then the non-dominant eye for a degree of nearsightedness where you can read. And this also kind of depends on what near target you want. So for example, if you spend most of your time at your phone, you're going to want to be able to see the phone up close. But then some people spend more time at a computer or a desktop computer, which sits a little bit further away. So you could adjust what that, quote unquote, nearsighted target is for the near seeing eye. And then of course your other eye would target for distance. So monovision's a really nice option for people who want to reduce glasses dependence. Some of the premium IOLs that we'll talk about in a little bit can be costly because they're not covered by your insurance, but because monovision still uses a traditional monofocal IOL, it's a less costly option for glasses independence. And also we'll go over there are some trade-offs with the multifocal or premium IOLs. And it's not an issue with the monovision because it's still using a monofocal IOL, which in theory will still provide the crispest vision at the particular distance that it's targeted for. A few things to consider with monovision: because each eye is set for a different distance or a different focal length, different target, there is a slight loss in depth perception because there's a difference in what each eye is seeing. There also might be an intermediate blur zone. So if you target one eye for distance and one eye for up close reading vision, the computer could be blurry slightly. Again, with astigmatism, you still have to consider and correct for astigmatism, especially in the distance eye. Depending on the amount of astigmatism, if it's not very much, you can probably get away with not correcting it in the near eye, but for the distance, you definitely want to correct even a small amount of astigmatism. And you also need time to adjust. Your brain needs time to get used to the different targets. With monovision, a lot of people have done monovision for years in contact lenses, and they're used to that difference in two eyes. So those are, it's really easy to consider monovision in those of you who have already done it in contact lenses, or some people have it naturally. If it's not something that's been tried before, and that is something that you're considering, we will often set you up with an optometrist to do what's called a contact lens trial, just to make sure that you're okay with having that different target in both eyes and the depth isn't an issue, because your brain does need some time to adjust for it. And then you might need glasses for certain things, depending on, maybe night driving, or if you're reading something really up close, but your near target is set more for the computer. So some things to consider with monovision. Next, I'm going to move on. I want to talk about what's known as the light adjustable lens. This is one of what we call premium IOLs. The light adjustable lens is a lens that's made of special photosensitive material, and it can actually be reshaped by directing a low intensity beam of ultraviolet light onto the lens. So essentially what that means is you can make adjustments to the lens power, which is the implant, the IOL lens power, after cataract surgery. So it can treat any residual refractive error. So let's say you had decided that I want to aim for near vision, but you aim for near vision in the surgery, but it's just you ended up having to hold things a little bit closer than you wanted to. So you can actually adjust the power of the lens to set it at the actual target that you prefer. These treatments are usually done in the office after the initial cataract surgery, and they're done about 3 weeks after the surgery, and multiple adjustments can be made over the next week or two before it becomes permanent. The reason I specifically bring this up here is because this can, like I said, be used to treat any residual refractive error, but if you're doing monovision, you can, with the light adjustable lens, you can actually customize your monovision to the exact, set target for that near target that you want. And then I want to move on to the other premium IOLs, which are probably the ones that you more commonly hear about, when you're talking to your friends about, or those who've had cataract surgery, or things that are, just very commonly known now. There are several types of premium IOLs, and there's something called the accommodating IOL. There are multifocal IOLs that can be bifocal or trifocals. And then there's also an extended depth of focus IOL. The accommodating IOL uses the natural movements of your eye's muscles to actually change focus. So the lens, it's a little bit bigger than the typical lens that you probably saw in the earlier photos or in the video that Dr. Ramanathan used. But it has, instead of just those little tiny foot plates, it has these hinges at the ends of the lens that will latch on. So this is the lens placed in the eye. So it actually latches on, and it'll move forward and backward in the eye in the same mechanism as normal accommodation. So in a normal eye, before you lose the reading vision, back in your 20s, 30s, when you can actually see far and up close, what happens in order to be able to read, the lens will actually thicken and it moves forward so you can see up close. So the accommodating lens will try to simulate that same function as a natural lens in the eye. The accommodating lens, because it's in order to see up close, it's actually just moving up. So in theory, it's still a monofocal lens. So when light comes in, it's still only focused on a single point. And what point that is depends on where that lens is in the eye. So because of this, it doesn't have some of the trade-offs that a multifocal lens will have that we'll talk about in a few minutes. But a lot of those side effects of the multifocal lens include halos, glares, loss of contrast sensitivity. So you likely won't have these issues with an accommodating IOL. However, the accommodating IOL, because it's latching on and moving forward and backward, it may not provide as much of a range of focus from near to far as some of the multifocals, and people may still need reading glasses for some near tasks. So you may not get that full range that you want with an accommodating IOL. The next thing that we'll talk about are the multifocal IOLs. So multifocal IOLs have multiple corrective zones built in, and it allows you to see both near and far objects. And essentially the lenses, there's several different types of multifocal IOLs from different companies that can be either bifocal or trifocal, but essentially they use various optical principles. A lot of them are proprietary technology, so we don't actually know exactly how the lens is working, but what I will tell you is that they all work in the same way, that they will split light rays. So you get both a distance and near focus if it's a bifocal, or a distance, intermediate, and near focal if it's a trifocal lens at all times. So there's actually 2 or 3 focal points for that lens at all times, but your brain, you're not going to see 3 things. Your brain learns to automatically select the focus that is appropriate for the task at hand. So even though the lens has 3 focal points for near, intermediate, and distance, if you're looking at something in the distance, your brain is only going to see that far object. But you do have that range of being able to see both distance, intermediate, and near with the multifocal IOLs. This is just one example of one of the multifocal IOLs that's available, and this is a PanOptix lens. And again, all of these lenses work a little bit differently in exactly how they split the light, but they do split the light into different focal points. So with the PanOptix, what the lens does, it is based on a 4 foci design. So the lens itself will split the light into 4 different focal points, but there's an optical technology in the lens that redistributes that focal point of one of those focal points to the distance target. So in essence, it's a trifocal lens, because in the end, it's going to end up splitting light into 3 focal points, where 50% of the light will go to the distance target, 25% to the intermediate, and 25% to the near. So it's a trifocal lens. The multifocal lenses are a really nice option to reduce spectacle dependence, but there are trade-offs, and you do this at the expense of some clarity and quality of your vision. So what does that mean? There is a chance of getting glare at night and halos, and then there's some reduced contrast sensitivity. And it's not that you won't see the 20/20 line on the chart. You will see 20/20. You might see 20/25. 20/20 is just the smallest line on the chart where we say that's perfect vision. And it's not that you're not going to see that, but it might not be as crisp as you would if you had a monofocal lens targeting for distance. So, nothing is 100% perfect. So it's a really nice option to get a nice range, but there are some trade-offs. There's also a process of neuroadaptation where the brain takes some time to learn to adapt to new stimuli. So if you were to put a multifocal lens in, it might take you a few weeks or even a couple of months to get used to it and really be able to see clearly. And the glare and halos also often do go away, but there is a small percentage of people where the glare and halos don't go away. So it is something that you do have to consider before you decide on having one of these lenses. And there's a little bit of a learning curve as well, because you do have to learn, what the new optimal distance for holding reading material is. You may have been used to holding things up really close, and you may have to push them back a little bit after a multifocal IOL. So it takes a little bit of thinking if you're going to use the lens, and also takes some time to get used to it. So the last lens that I wanted to talk about is the extended depth of focus IOL. So the extended depth of focus IOL, unlike the multifocals, it only has one corrective zone, so it doesn't split light rays. However, what it does, instead of focusing on one single point, it actually creates a stretched or elongated focal point. So it enhances or improves your range of vision. So they don't split the rays, but they elongate the focal point. So you get a little bit more continuous spectrum of sharp vision from distance through intermediate. It doesn't quite reach all the way up to near, so you would still need glasses for near vision, like reading or your phone, depending on how close you use it. But you do get distance through intermediate, and by intermediate, I would mean like computer length, something like that. And this is, again, one example of an extended depth of focus lens. This is known as the Acrosoft Vivity. So you've got your lens and light focuses through. It doesn't get split, but you have an elongated focus here. So from distance to intermediate, which is nice and clear. So you get a little closer to near, it blurs a little bit. So the best vision you're going to get is going to be from distance through intermediate with an extended depth of focus lens. So overall, with the extended depth of focus, or EDOF, there should be less glare and halos and less loss of contrast because you're not splitting light. But again, there is still a chance of these things because you are elongating the focal point, but less so than a multifocal lens that will split the light. And it's good for distance or intermediate, but you'll likely need a low power reading glass post-operatively for closer tasks. So those are the different types of premium lenses, and there's a lot. And these are most of the ones available in the US, but there are some others that aren't listed here. But you've got your accommodating lenses, you've got your multifocal lenses, and then you have your extended depth of focus lens. And then that doesn't include the monovision that we talked about, or just the standard monofocal lens. And again, I'll just say this again, that all of these lenses are available in toric or astigmatism correcting versions as well. So which lens do you choose? You know, there's a lot of options and it's a difficult decision, and it's really different for every individual. There's a lot of things to consider, and it's a discussion that you have with yourself and your ophthalmologist to try to come up with what the best lens is for you. So there's a few things that you have to think about. One is, you have to evaluate, of course, your baseline ocular health and status, because some of these options may not even be a good choice depending on some other eye conditions. Really want to understand your lifestyle needs and what your visual expectations are. Consider cost. And then based on all of those things, you'll be able to select a lens that, you know, based on the benefits of the lens and the limitations and what is best for you. So we'll go over some of these things. So first is ocular health. And this, of course, is going to be done at your preoperative exam. Are there any other eye conditions? Because if there are any abnormalities, like glaucoma or macular degeneration, which you'll hear about in the later lectures, some of these things could limit visual acuity, contrast, color, or field of vision. And if this is the case, you don't want to put in a premium lens because you're not going to get the greatest benefit out of the premium lens because you already have, because there's already some sort of limitation. But it could also actually, not only that, but it could make some things worse. If you have any conditions that limit contrast or could already cause glare and halos, it could make those things worse if you put in a multifocal lens in an eye that has some of these abnormalities. So that you have to be really careful about that. Other abnormalities to look for that could make glare and halos worse include any ocular surface disease or severely dry eyes. If you do have really dry eyes, you want to think twice before putting in a multifocal lens because the glare and halos could actually be worse afterwards. And then if there is an abnormality, you need to decide, is it significant or is it progressive? And that'll kind of help guide you towards which direction in terms of IOLs you want to go for. Then it comes to the lifestyle question. So the first thing to ask is, how important is really, really sharp vision with or without glasses? That's one question. And then the second thing is, how important is spectacle independence? And you can use the answer to those questions to kind of guide which way you want to go with the different types of lens options. And then you want to ask yourself, what activities do you like to do? And what do you want to do? What types of activities would you like to avoid glasses for? So do you spend most of your time outdoors? You know, are you hiking or biking and do you not want to have to wear glasses for that? But then are you doing certain things like golf or tennis where depth perception is important? Because this might, you know, if you're an outdoor person, you still want to be able to read, you could do monovision, but then if depth perception is an issue, monovision may not be the best option. So those are some of the questions you have to think about when it comes in terms of outdoor activities. Then what about driving? You know, do you want to be able to drive without glasses? But then if that's the case, do you drive at night a lot? Because with the multifocals, sometimes glare and halos are an issue. So you don't want to have to deal with that with night driving. So if it's really important for you to have sharp driving distance, but you do drive at night, then maybe a monofocal, just distance correcting lens is a good option. Then, does your lifestyle rely on near and intermediate vision? And do you want to wear glasses or not want to wear glasses for certain things? So when we talk about near and intermediate vision, there's a lot of things that could be, right? Do you spend most of your time reading a book or an iPad or a Kindle, or do you spend more of your time on your phone, or are you at the computer more? Because all of these things are slightly at a different reading distance, and that will kind of help guide you on what type of lens you want. So for example, if you spend all of your time, near, in terms of near tasks, if you're at a computer all the time, then maybe you want to consider one of the options that corrects, for distance and intermediate, like an extended depth of focus lens, because then you won't have to deal with some of the glare and halos that come with the multifocal, and you're not spending a lot of time up close, so the reading doesn't bother you. So you really want to think about these things as well. And you might just say, look, I spend all my time on a computer or on my phone, but I'm okay wearing glasses for that. So that's can lead you down a different direction. So for each of these things, you want to think about your lifestyle, but then think about, what it is that you may or may not want to wear glasses for and what you're okay with. And then I do have to bring up costs, because that is going to be one of the factors that comes into making your decision. Medicare and most insurance companies will cover the cost of monofocal lenses, but they don't cover the other lens options like the torics, the light adjustable, multifocals, extended depth of focus, and the accommodative lenses, because these are considered premium lenses that you don't, they're not medically necessary, because what they fix could be fixed by glasses. So that's why they cover the monofocal lenses, because you have to put a lens in after you take the cataract out. It doesn't have to be a lens that allows you to never wear glasses, but you still have to put a lens in. So, and some of the costs can be quite pricey. I mean, every practice has, different costs, but just if you think about ranges, the toric lenses can start around 1,000, 1,200 and upwards. Some of the premium lenses, multifocals, extended depth of focus, can start 2,500, 2,800, all the way up to 3,500, 3,800, depending on the practice. So, and that's per eye. So of course it can get costly. So that's definitely a factor to consider. I will mention that some of the IOL manufacturing companies that actually make the lenses have what's called a resident and fellow training program with academic institutions, including UCSF, but just across the country. A lot of academic institutions have this program because it's a teaching institution, and that can really help cut out the cost, cut down a lot of the out-of-pocket costs for the premium lenses. So that is something that you can also consider. So now that you've thought about all these things, you're ready to figure out what the best lens for your eyes, your lifestyle, and your budget. So just to, kind of reiterate some of the important points when it comes to choosing an intraocular lens. If your main concern is sharpest and clearest vision, would consider doing a monofocal lens. Of course, it does mean having to wear glasses for certain things, but that will give you the sharpest and clearest vision. Then you want to think about, your lifestyle needs and your visual expectations. Consider monovision or premium lenses if you're really motivated for spectacle independence and at the same time willing to accept some of the trade-offs. You do want to avoid the premium IOLs if you have any ocular pathology that can limit visual potential. And of course, have realistic expectations, consider the cost, if that's a factor. And all of this requires time for discussion and thought, and it often can require a second preoperative visit with your ophthalmologist. You go to the first visit, you decide, okay, I have a cataract, I need surgery, but then this whole lens thing, you can imagine, can be a lot of thoughts. If you're not quite sure what you want, it's always okay to make a second visit, because you can think about some things and come up with more questions, and then make the decision at that second visit. So I'm going to change gears a little bit. You've learned about cataract surgery. Let's say you've picked a lens and you've had a great outcome, but what do you expect after the surgery? So you will go home the same day. It's one-day surgery. Usually it takes about 30 minutes or so, and You can expect to go to the ambulatory, if it's an ambulatory surgical center, but the surgical center a couple of hours before your surgery. Surgery takes about 30 minutes, and then you stay there for 30, 40 minutes, and then you go home that same afternoon or evening. Expect to wear a patch or a shield overnight. And then every doctor has, their own drop regimen, but you will be on drops for around 4 weeks. And again, some people may do 3, some people may do 2, some people may do 6, but around 4 weeks in some form of an antibiotic and an anti-inflammatory drop. In terms of activity restrictions, these are usually for 1 to 2 weeks. And the restrictions are weight-bearing activities, usually anything more than 10, 15 pounds. No bending or inversions like yoga, stretching. You want to avoid high impact activities like running, avoid swimming, and then eye makeup as well for 1 to 2 weeks. But the things that you can do per your comfort, you can drive if you're comfortable, if you feel like your vision's clear enough, TV, reading, computer, just walking around. These are all okay depending on your comfort level after the surgery. And then in terms of how many visits you have to have after the surgery, you'll always be seen the day after surgery. And then usually you'll be seen at 1 or 2 weeks. This visit, depending on how you look at on day 1, can be skipped, or often we're actually doing a lot of them by phone now. And then you will have an in-person visit at 4 to 6 weeks, either with the ophthalmologist that did your surgery or an optometrist, because this will be your final post-op check. And then you'll also get your glasses prescription if you need one at this point. So, people always ask, how long do I have to wait for my new glasses? Usually about 4 weeks, so everything's settled and you're well healed. And if both eyes are being done, again, everyone has different regimens on how they space the eyes apart, but on average, if you're not doing them both on the same day, which some people are doing now, including us, but if you're doing them separately, on average, usually about 2 weeks apart. So if you're thinking about, if I do my eyes 2 weeks apart, when am I going to get my glasses? About 6 weeks. And then just after, you're all done, you've got your glasses prescription, what do you do then? You should still, of course, get yearly eye exams just for annuals, especially if you have any other eye conditions that need to be monitored. Cataracts do not come back, and the lens doesn't have an expiration date, or it doesn't need to be replaced. It's there forever, unless there's some sort of trauma. The one thing that can happen is it's something that's known as PCO, or posterior capsular opacification. And what this is if you remember from Dr. Ramanathan's analogy, we have that M&M and we leave that candy coating intact, right? We take everything out from the inside and we put the implant in its place. Sometimes that candy coating, the back part of that candy coating can get cloudy. And that's what posterior capsular opacification is. And, sometimes it's referred to as a membrane, sometimes it's referred to as clouding or scar tissue, but it's essentially clouding of the back part of that capsule. So symptomatically, it feels like you're getting your cataract back, because if you can imagine, if the capsule is cloudy or that shell is cloudy, your vision's going to be blurry again. And this top picture is what it looks like, just a clouding, and that clouding is in the capsule or the shell of that lens. And this is a very in-off treatable condition in the office. It's just done with a laser in the office. It's called a YAG laser capsulotomy, where essentially we use a laser to kind of break up that scar tissue or that membrane and just create a clear central opening, so then that your visual axis is clear again, and then you can see clearly again. And again, this is just a 5 to 10 minute procedure done in the office. You go, you get it done, you go home the same day, no restrictions. So that brings us towards the end of our talk. Just a few kind of final points to remember from both parts. The cataract is an opacification of the lens. Cataract surgery is warranted when you're not able to perform visual tasks and glasses no longer provide any visual improvement. So we commonly say that as when cataracts are affecting your activities of daily living. There are many different types of lens implant options, and all of them have their own various benefits and trade-offs. So the decision-making process around selecting an IOL involves several factors, including your baseline ocular health, lifestyle needs, and your visual expectations. That brings us to the end of our talk. Thank you guys very much. And I know there's a lot of questions in the Q&A. We purposely left them for towards the end because we knew we'd have a lot of time at the end to answer questions. So I'm going to stop sharing and then we will go through the Q&A and answer all of your questions. And please keep adding more if you have more questions. So the first question is, I've been using monovision contact lenses for 25 years, which I've been very happy with. When I used to go see live performances in large theaters, I would take out my reading glasses and leave the distance lens in. I will take out my reading lens and leave the distance lens in. I will need cataract surgery in the next few years rather than getting monovision lenses. Can I get 2 distance lenses and use it? Yes, you absolutely can. You can still use contacts after cataract surgery. So if you decided I want to just get good, clear distance vision, you target both eyes for distance, and then you still have the option to get fit. It'll be a different prescription, but to get fit for a contact lens for near and to wear it in one eye. So then you have the option of monovision when you want it, and then you have your clear distance vision in both eyes when you want it. So you can definitely still do a contact lens for monovision after cataract surgery. Dr. Ramanathan, I'll let you answer this one. How can you pierce the lens without rupturing it?
So when we take that cataract out, remember, we keep the lens capsule in place. So when I was showing you that video, remember the first thing I showed you was tearing and opening in that capsule, the hard candy coating of the M&M. And then we work inside the capsule and the capsule stays in place. We do pierce the lens because we're trying to take the entire lens out. So first we cut it in half, then in sixths. So we cut each half into 3 more pieces, and then we take each of those pieces out. So we're definitely rupturing the lens. We're breaking the lens apart and removing it, but we're not rupturing the lens capsule. It's like a bag, like a purse, if you will, that holds that lens in it. We're working inside that bag, inside that purse. So that's why, that's how we're able to do it. And that, of course, is why it's a complex surgery, because we're working in a very tight space. You are absolutely right to say, hey, isn't it possible that you could rupture, you could tear that capsule? Absolutely. The overall risk of something like that happening is about 2 to 4%. It can be higher in certain with certain underlying conditions, or when someone has had trauma or previous surgery to the eye. So the risk is very low, but it's not 0. But that's why we don't do cataract surgery on everybody. That's why we try other options first, because there is some risk of doing damage and having nowhere to put that lens implant. Neeti, can you talk about LASIK and how that affects it?
I'm just going to get to that question because I love that question.
That's a great question.
It's actually a really, really good question. So the answer is it impacts the lens choice. So what LASIK or PRK or refractive surgery, which you guys will hear about with Dr. Schellhorn, what it does, it essentially changes the shape of your cornea. So it changes the power of your cornea. So you can see distance or near without glasses. It doesn't affect the cataract. So you get, let's say you're nearsighted and you get LASIK when you were 25, so you no longer had to wear glasses because it corrected your distance vision. And then 50 years later, 60 years later, you develop a cataract. So the cataract is going to cause your vision to get blurry again. So you do need cataract surgery. But what the LASIK does is, because it's changed the power of your cornea, it affects the lens power that we choose, because when we choose which lens, and this is for all of the different types of lens options, but when we choose the actual power of the lens that goes into the eye, we use measurements of your eye. And those measurements include the length of your eye. The most important things are the length of your eye and then your corneal curvature or your total power of the cornea. But LASIK has changed that, and it hasn't changed it uniformly. So when we do the measurements that we get are not going to be accurate for measuring the power lens to put in the eye. So we have different types of what we call IOL calculators now that we can plug in all these numbers to actually get the correct lens, but they're still they're great. I mean, they've changed and the range that we get is really tight now, but there is still a chance that you could be left just slightly nearsighted or farsighted. And it's a very small error, but you do have to know that. when you're getting cataract surgery after having had LASIK, because there's a slight chance that you might still need glasses for driving at night or for reading. And then the last thing I'll say about that is LASIK, because it changes, it doesn't uniformly change the curvature of your eye. Putting in a multifocal lens in an eye that's had LASIK is not the greatest idea. And it's something that I think most of us shy away from because of that risk of glare and halos, because then if you think about it, if you've ununiformly changed the shape of your cornea, it's kind of a multifocal cornea, and then you're putting in a multifocal lens in, your chances of getting glare and halos are much higher. So we usually don't like to put in a multifocal lens in an eye that had LASIK, but you could do monofocal, you could do monovision, lots of options. But that's just something to keep in mind with that.
There are 3 questions that have to do with with cataract surgery in eyes that have other problems. One person asked about epiretinal membrane, one person asked about dry eye, and another person asked about floaters. So if I may, I'm going to answer all 3 of those questions together. Cataract surgery in itself doesn't give you more floaters, but it will make the floaters that you have clearer and more visible. You will, just like you see the whole world more clearly, you will see your floaters again more clearly, and it will seem like you have more. They were always there. It's just that the view of them was blocked a little bit by the floaters. As far as epiretinal membrane, Dr. Parikh talked about this a little bit in terms of, or did I don't remember. Anyway, in terms of other diseases, if you have other diseases of the eye, it does not preclude having your cataract removed. In fact, we're often aggressive about taking out the cataracts because that's one thing we can do safely and effectively to help optimize the vision that you do have. However, we may choose a more conservative lens implant so that you don't have more blur or distortion, especially if you have retinal disease like diabetic eye disease, macular degeneration, or epiretinal membrane, or some other type of retinal disease. Now, as far as dry eye goes, anytime you operate on the front part of the eye, you can make the dry eye a little bit worse. We always try to optimize our patients' dry eye condition first before we operate, but often people for about, 6 weeks or so afterwards, 6 weeks to several months afterwards, will have they'll have a slow sort of return to their baseline in terms of dry eye. And some people just get more dry after cataract surgery. It's very possible.
There's 2 questions on premium IOLs. So one of the questions was, why do so many people have trouble with premium IOLs? And I will say there are a lot of people that are happy with them, but with the glare and halos and the contrast, it's because the multifocal split light rays. So if you think about it, you're not getting 100% of light to the distance target or the near target. So you're splitting the light. So the quality or the clarity of the image just may not be as sharp as it would with the monofocal. So that's what the issue is with multifocals. And that being said, it's still a really good lens. The vision is great. It's not that it's bad vision, but it's maybe not what you would get with the monofocal. Exactly. And it also depends on what you're doing. I mean, it's going to become most important with, tasks that need super, super fine vision, like just driving at night or something like that. So that kind of brings me to the next question, which is, what do you do in the informed consent process to temper expectations in patients that are paying thousands for premium IOLs? Exactly what we just did. So you have to be honest. You have to tell them everything. But at the same time, if knowing all that, if you're willing to accept some of those trade-offs, it's a really nice option to get spectacle independence. But the most important thing is just, to be honest and tell everybody, we all tell all of our patients what those trade-offs are, and then kind of weigh the benefits and the trade-offs and the glasses independence, the importance of glasses independence, and kind of go from there. So I'm just going back to Ralph Jacobson's question. So it sounds like if there was a video, it didn't see the video. So maybe do you think you could share your screen again and go through the video part again?
So here you can see I am tearing that capsule so that I can make a little opening in that purse. So this is really the mouth of the purse, if you will. I'm tearing some tiny opening in that very flimsy membrane. That's that chocolate coating, or the blue outer candy coating. Now I've inserted my lens implant. I'm taking the second instrument that is going to help me chop this up. And I'm working inside the capsule. All my instruments are inside the capsule. The capsule is just so thin you can't see it very well. You can sort of see it, but very difficult. Now, look how I'm chopping. We call it chopping. I'm chopping that lens, that cataractus lens, into 6 pieces, six little pieces of pie. And then I'm sucking each one out through the mouth of that purse, through the opening in the capsule, and I'm eating it up right in the middle. And I'm leaving the capsule intact as I do it. So I've chopped it up into pieces. Now I'm eating that cataractus lens. Someone in the chat said, do you mean lens or cataract? Well, they're the same. An opacified lens is cataract. So I'm chopping up and eating up the cataract, that hard nut part of the center of my peanut M&M, if you will. And it's the ultrasound that helps me cut that up into small pieces. It also is my second instrument that I'm holding on the left side. That helps chop it too. Now I use just a vacuum cleaner, if you will, to clean out, to suck out the chocolate. That's the soft part of the cataract that's outside the nut. Now you can see that window that's in place, that I've left in place, that opening in the hard candy coating, the opening of the purse, if you will. And now I'm putting that lens right inside the purse, right inside the capsule, the candy coating, and I let it unfurl and we're done.
Awesome. And then there was a question kind of relating to that, and I think this refers to the capsule, but does the eye membrane heal itself after the incision? And I think that refers to.
Yeah, that opening doesn't heal up, that stays open. And we like that because remember, Dr. Parikh told us that after many years, the backside of the capsule can scar up a little bit, become opacified. And for that, we do laser treatment to create another opening, roundish opening on the backside of the capsule so we can see through it.
And then somebody just, oh great, he saw the video this time, so that's great.
Yay!
And then to answer the question if the lens opens incorrectly, I'm assuming you mean the lens that
IOL, yeah.
We don't like it, but it's easily fixable. We can actually, we have a lot of this jelly that we put in the eye when we put the lens in to protect all the other, protect that capsule and all the surroundings. So we can use 2 instruments to flip that lens in the right orientation or the right way. It's not that difficult. Of course, we don't like it because we want everything to go really smoothly and everything, but it's very easily fixable and it takes a minute.
And if we do tear, someone else asked the question, if we do tear the capsule, what do we do? There are different lenses that we can put in that don't need to be placed inside the capsule. They can be placed elsewhere in front of the capsule or even in front of the pupil. We can use those lenses also if that capsule gets torn.
And then Dr. Ramanathan is on the OR committee, so I'll let her answer this question. How many cataract surgeries are done at UCSF every year?
Oh, right. We do something, every surgeon is different, but we do something like 1,000 cataract surgeries between all of us per year. There are some of us, Dr. Parikh and I do the majority of the cataracts that are done at UCSF. That is the majority of our practice. And so each of us do somewhere between 7 and 10 a week at multiple different sites. So there, you can see that we're doing a lot of cases. Actually, 1,000 is probably too low a number. Anyhow, but a lot.
So there was a question that I saw another one, but they're both about the same regarding changing your mind about the type of lens or changing the lens down the road. So that's something that's known as an IOL exchange. And when you put the lens into that capsule, into that bag, with time, the lips or the leaflets of the capsule fuse. So removing the lens and putting a new one in becomes a lot more difficult. So we don't, when we're, choosing the right type of lens is difficult, but we do say this, you have to go into it thinking it's a permanent decision. I mean, yes, if we do it early enough, can we take it out and put a new lens in? Yes, but it is risky because when you take out the original lens, if you rip the bag or anything, you're looking at a much more complex surgery than just having to, wear glasses because you picked the wrong lens or something like that. So that's why we spend so much time, helping you or letting you take the time to make the decision for which type of lens to put in, because we really want to avoid doing the IOL exchange. That being said, it is definitely possible, and we've all done them. Sometimes, you might choose a multifocal lens knowing everything, but that glare and halos is just really, really bothersome. And it's just not possible to live with it. So we can take that multifocal lens out and put a monofocal lens. So it is doable. It's not common practice. And it is doable, and it's much better to do it sooner rather than later, because then there's less of a chance of everything kind of being scarred in and fused. So the risks are much lower.
There were a couple of questions about post-operative sequence in the bilateral versus immediate, bilateral versus consecutive. If you do have the two eyes done on the same day, then you do the post-operative regimen for both eyes at the same time. If you have them done separately, then you're going to be doing the post-operative regimen for one eye, and then when the second eye is done, you may not be done with the first eye, the drops in the first eye, before you start doing drops in the second eye, and you may have to. The question was, do you double that? And I'd say you overlap those two courses.
And then there's a question on the IOL options. Are all of these IOL options available for Christmas tree, myotonic dystrophy, cataracts? Yes, because the essential cataract surgery is the same. And then I just lost the question, but there was something about insurance in the premium lenses. So in essence, insurances doesn't matter what type of insurance, but I would say most, if not all, insurances don't cover the premium lenses. And most of all do cover the monofocal lenses.
Neeti, there are a couple of questions about distance vision. Where does near vision end and distance vision start? And what's the length of focus, 10 feet, 50 feet? So I think both these questions ask about the focal length.
So intermediate vision computer is about 30 inches. So a little bit less, like around 2 feet, 2.5 feet. Near vision is around 14 inches. Past that, so past the computer, that's all distance. And then what distance goes to, I mean, technically it's infinity, but there's, at some point you can't see infinity, but distance is everything from about intermediate, so everything from about 30 inches to beyond.
There are 3 more questions about other eye conditions. So ocular migraine, age-related macular degeneration, and myopia causing macular hole tractional detachment. So again, first, the macular degeneration and macular hole tractional detachment. The one thing that we must that we always tell all of our patients is, if there is retinal pathology, whether it's an epiretinal membrane, whether it's macular degeneration or macular hole retinal detachment, any kind of surgery on the eye makes the risk of any of those worsen. It increases the risk of worsening. Not a huge increase in risk, but it does increase the risk. So we really weigh that in our decision to operate or not operate. If there is, but we don't avoid cataract surgery because you have macular degeneration. In fact, we might choose it a little bit earlier because we want to optimize what we can do. But we'd have very close follow-up with the retina, your retina provider. Following the surgery, you might, if you're getting injections in your eye, which you'll learn about at the next lecture, you might get an injection just before cataract surgery or just after to keep that macular degeneration at bay. If you have had a retinal tear or retinal hole, you would probably have we'd probably arrange for you to see your retina doctor very soon after cataract surgery to prophylactically look for any new retinal pathology after cataract surgery. If you have, so the ocular migraine question, if you have ocular migraines, it depends on what triggers it. I suppose it's conceivable that a multifocal lens, because you have multiple different images, maybe that might trigger an ocular migraine, maybe not. We don't necessarily avoid those premium IOLs in patients with ocular migraine, but again, we would definitely take it into consideration. That's what I would do. What do you think, Neeti? Anything to add on that?
I mean, I think it depends. Again, it's that, how progressive are these conditions. So if you're getting migraines all the time, I don't. That's something to consider when if you're putting in a multifocal, because you don't want to make anything in terms of glare halos worse. But if it's something that you've gotten once and got again, 3 years later, and that was it, then I think you kind of have to weigh that into consideration. But it's something to consider. It's not a definite no. There's a few questions here that I see them in a row, so I'm going to answer them in a row.
Yeah.
Advances in IOL technology are amazing. What do you predict for the future? And maybe I'll wait as long as possible just to get the latest innovations. So it is changing all the time. And I feel like every 6 months, there's a new lens option available or there's technology available. So I think, things will continue to change and there'll definitely be more options available, but that's going to keep happening. So I don't know if waiting till the latest innovation, because there's always going to be a new latest innovation. So I think the first question to answer is, is your vision, because what we have now, the options are great. So, when you're deciding on cataract surgery, it's, if you need it now, I don't think that there's any reason to wait for something newer, because there's always going to be something newer. I mean, I think that applies to a lot of things in life, but, we have some really, really great options now. And I think there's going to be newer ones in the future, but everything, I don't know that you necessarily need to wait if you need the surgery for visual rehabilitation. And then there's a couple of questions on the sedation. So we do it under local anesthesia. So you get numbing medicine in or around the eye, and then you just get a little bit of sedation through the IV. We don't actually like you completely asleep because we don't want you to wake up all of a sudden, because then you'll move. So we kind of keep you in this twilight happy zone that you're still awake and we can talk to you during the surgery. And I know some people ask if they can do it without being conscious because they're terrified. We typically don't do these under general anesthesia unless there's, a really good reason to, if somebody's really claustrophobic or something like that, just because there are risks to general anesthesia and for such a short procedure, and knowing we can do it very safely with moderate sedation, we typically like to do it under moderate sedation, but it can be done under general if there's a good reason to.
Signs and symptoms of infection post-operatively. We really do. That's why we see people at, we need to see everybody in the first 24 to 48 hours after surgery. We usually choose the day after surgery. We like to see you that day. And then we have to check in with you at a week. Because whether it's in person or through a telehealth visit, we want to make sure that you're still continuing to see well, that you have no pain, and that your eye isn't red or uncomfortable. Most people in the first week, most of their swelling resolves and they are seen pretty well. They are pain-free. They're going back to all their usual activities. And so if there's any deviation from that, we would see you back. If there's been anything, we have a very low threshold for seeing people in person at post-op 1 week. And so we would, even if the threshold is if you wanted to come and be seen in person, we would do that, no problem. But if there's anything even sort of suspicious at post-op day 1, we would see you back in a week. And it is usually in that first week that we look for any signs of infection.
And then there's a question on, is there any downside to clear lens extraction with IOL implants to correct refractive error in people older than 65, but not yet having a cataract? I can start with answering that. I mean, it's still surgery. There's always risks. So we always want to weigh the risks and the benefits. So just in general, risks of cataract surgery are going to be, bleeding, infection. There's that risk of getting a posterior capsular rupture. Really rare, but it can happen. One of the other risks of cataract surgery is getting a retinal tear detachment, but it's actually higher in those under 50 if you're looking at age as a consideration. But when you're I would say the downside of doing a clear lens exchange is that the risks may outweigh the benefits. But that being said, there's probably some sort of a cataract there at 65. So that's my answer to that. What do you think, Saras?
Yeah, I think so. I think it's rare that people don't have a cataract. I usually say cataracts start developing sometime in your 50s, and by 65, most people have some kind of cataract. Having said that, there are lots of good reasons for clear lens extraction. Some of them have to do with glaucoma, asymmetry between the two eyes. One eye becomes really nearsighted from cataract, the other eye isn't, and so it's really hard to resolve that even with glasses. So there are good reasons to do clear lens extraction. But we don't generally do it just because you have refractive error and we want to fix that. We generally choose some type of spectacle contact lens solution for that. Again, we're pretty conservative here at UCSF. We always weigh the risks and the benefits.
There's a question, do you recommend a specific lens when the patient has ocular rosacea? So I will say with ocular rosacea, what goes hand in hand with ocular rosacea is ocular surface disease or dry eyes. So that being said, you really probably want to shy away from doing a multifocal lens because the risk of glare and halos can be worse if you put that in a patient with dry eyes. So I would probably lean towards one of the monofocal lenses. Whether you want to correct for distance or near, doesn't matter. Or you could even do monovision if that's something that's been done in the past. But the dry eyes will definitely affect the healing and maybe the final quality of your vision. So I wouldn't recommend doing one of the premium or multifocal lenses. Let's see, I think we probably have time for one or two more questions. If vision acuity changes over a lifetime, does this continue to be a concern after lens replacement? Your vision can still change a little bit, and your prescription may change, from year 1 to year 3 after cataract surgery, but it's the really minor changes. It's not the kind of large changes in prescription that you're used to your whole life, when you went from a -1 to a -2 to a -3 over a course of 10 years or something like that. I'm talking, minus a quarter, minus a half, very minuscule changes in your prescription for that.
Tips on keeping our lenses nice and healthy. I like that one. I always tell my patients to wear sunglasses anytime you go outside. There's more sun than you think. And so I think sunglasses are very good, especially ones with UVA, UVB, and polarization, UVA, UVB protection and polarized. I tell people to eat a really healthy diet full of antioxidants because cataracts are really a problem of oxidization of those lens proteins. So a nice healthy diet filled with all those leafy green vegetables, all those things that we're supposed to eat plenty of. I don't tell people to take a vitamin, but I also don't tell people that their vitamins are useless. If you want to take a one-a-day vitamin, I don't think that's a bad thing. But I think those are the main things. Did I leave anything out, Neeti?
No, that's pretty much it. Sunglasses are the big thing too for everybody. And I always get asked, do I have to continue? Because we tell you to use sunglasses after the surgery. Do I have to keep using them? Yes, you should. Because it's not just for the cataract, but for other things too. All right. I know we didn't get to a couple of these, but I think we're at time. Thank you all very, very much for joining. I hope this was somewhat informative and helpful, and we really appreciate so many of you joining us tonight.